And then I am going to welcome Nancy Ruffner, who is a patient advocate and a solo ager, who is going to lead us in a discussion today. And Nancy, I am delighted that our paths crossed. And the first time we met, Nancy took advantage of, I think, on one of these discussions, I was like, look, you all can uh, sign up and schedule a meeting with me on my calendar. And she took me up on that offer. And the moment I started talking to her, I was like, okay, I got to have you on one of these discussions. So I'm glad that that day has finally come, Nancy.
Me as well.
Yeah, so I know you've got a PowerPoint and we're going to dive in to our discussion, but before we do that, I always like to get to know our panel member better. So tell us a little bit about your background and what led to what you're doing at this chapter in life.
Happy to. First, let me thank you, Steve, for your interest in patient advocacy and for solo aging. I really appreciate the platform. I have a family story like so many others. My impetus or the genesis for my patient advocacy agency came from healthcare debacle. And I'll talk a little bit about that as we go on. It made me go back to school. I had an undergrad BSW in social work, but it led me to pursue my master's work in counselor education and jump in feet first, leaving one job and going straight into patient advocacy. And here I am.
Oh, that's great. I was just typing something into chat, just reminding folks that the recording, the chat transcript, and we'll also do a podcast recording of this as well. It'll all be at our website this afternoon. So if you want to share this or if you have to jump off early, it'll be available. Okay, well, this is great. And actually, I think I saw. Okay. Okay. Well, this is good. Before we even talked, Fran is fielding a question, and I'm gonna give this one to you, Nancy, because I'm pretty confident it's gonna be in your discussion. But it says, I'm an RN licensed in a few states. I'm very interested in becoming a BCPA. Can I reach out to you with questions or an email? Well, Nancy, the first thing I want to know is, what is a BCPA?
Sure. It means board certified patient advocate. It is our certification board that enables our strict adherence to a code of ethics, a standard of practice, and it's a certification that's international. I will talk a little bit about that, but I welcome anybody to reach out to me. You can email me at nancy@nancyruffner.com. I want to shepherd people into our industry as well. There's a lot of need and a lot of very good work.
Great. Okay, and I'm dropping your email in there just in case we don't we miss that and we get carried away with answering questions. So today's discussion is going to intersect between patient advocacy and solo aging. But for those of you who have not been on one of our solo aging discussions, I am delighted that I stumbled into this term, and that's what I would call it, because how you identify yourself is entirely up to you, and how you identify someone as a solo ager, or you as a solo ager, or your loved one as a solo ager, is completely up to you. But one of the things that I love about this term, solo aging, is that so many people wear that proudly. Is that many people that I talk to, they're not ashamed of being a solo ager. It's more, hey, I'm a solo ager and I'm trying to figure out, is there somebody I can pay to be my healthcare power of attorney? Because I don't really have a network or a family member that I trust for that. But the thing that I love the most about solo aging is when I go to a barbecue and I tell people, oh, our number one topic that we talk about is solo aging. And oftentimes I'll get, oh, I don't need to worry about that because I'm married and I got 3 kids. And they'll say, really? So you and your wife, you're confident that you're going to pass away on the same day, right? And then they look at me. It's like, wow, that doesn't happen that often. And then those 3 kids, you're planning on just letting them make all the decisions without your feedback? Oh, wow. And so, but here's what I love about solo aging. If I say to that same person, you got to map out a plan. Someday you might need assisted living. Their answer is going to be like, I'm not ready for that. It'll be okay. But if you say to that person, now that they've acknowledged that more than likely they're going to outlive their spouse or they want to be in control of their future, and you say, why don't you map out a solo aging plan? All of a sudden it becomes a little bit more digestible, because let's face it, nobody wants to talk or think about any of this stuff that we've got in Sourcebook. But we all know that if you don't plan and you don't talk about it, then you create a crisis for yourself and your network. So that's my soapbox speech on how wonderful I think these discussions on solo aging are. I want to remind everybody to just interact, and then I'm going to jump off the stage and let Nancy begin her discussion. Does that sound good, Nancy?
Yeah, I'm ready.
Okay. And so hopefully the sharing feature is going to work. And
Here we go.
it works. There you go. I'm going to stop my video, and folks, Nancy, just shout out if you need me.
Great. Sounds good. I appreciate it if you monitor the chat for us, because I'm sure it will be livelier and provoke some thought and question. Thank you for the opportunity to be here again today to talk about what I think is an important intersection, and that's patient advocacy, my career, and Solo Agers, my lifestyle. There's some interesting history to the field of patient advocacy. You know, we were only born in about 2009. We came about because there was a need for advocacy outside of the hospital. We may be familiar with the term patient advocacy because of hospital patient advocates, and they're valuable, they're useful, and they can get things done. But after discharge, you know, they stay there and you go where? And so we saw a need. We saw our patients cycling from home to hospital to rehab to home, or can't go back home, need a new home. And so an industry was born of largely nurses and social workers, and we remain largely so. However, among the ranks have joined pharmacists, paralegals, doctors, nurses, a plethora of helping vocations have joined the ranks. We have some professional organizations, and I can try to get those in the chat later on for you, and certainly talk with you about them. But our main ones are the Alliance of Professional Health Advocates, National Association of Health Advocacy Consultants, Health Advocate X, and Greater National Advocates. When you Google patient advocate and your state, for me, patient advocate North Carolina, we will pop up, and our search by zip code directories will too. Our industry was brought to board certification. That took a few years to develop the certification and to test it and to begin to have people to take the exam. And many have. We've got a little over 1,200 nationwide. A lot more people than that are doing patient advocacy, but didn't choose to pursue this particular certification. Now, how you find us? Again, Google. Google patient advocate your state, and we should come up. Those professional organizations with their search by zip code directories will as well. What do? We are here to ensure your clarity and your understanding of medical issues and more. Everything from a new diagnosis what's this new diagnosis and how's it going to affect me and my family? What's the treatment for this? I don't understand legal documents. What are advanced directives? How do I find a new doctor? Mine's retiring. Or how can I get the health care that I deserve? How do I understand this hospital system? What do I do next? How does stuff work? And how can I get the information I need to make good decisions? Sometimes we step in, sometimes we act as buffers between family members, loved ones, healthcare providers, staff of certain communities and facilities. But our job is to get you the information and to ask the questions for you that you may not know to ask. So we're spotting mistakes, missed handoffs, misinformation, and missed opportunities. All right. My why, let's see, my why I'm here. I had a family story like many other folks. My sister and I thought, as our parents began to age and change, that we were the two best daughters on the planet, ready for this. I was working for an EAP on the legal and financial and elder care teams, and doing the intake assessment, research, referral, just like I do now, but I was caught under a headset. My sister was working for the ombudsman as the program support, and we just thought we had all the answers. What we found was completely different, and we met with debacle. We met with those missed handoffs and those misinformation and missed mistakes. And so we became estranged and distant in the care of our own loved ones. And we made there came a time when we didn't even speak. And both of us felt that feeling that I can only describe as arg, and overwhelmed. And it was so strong in me that I thought, if I can do anything to prevent anyone from feeling this overwhelm and this uncertainty and this fear, then that's what I'm put on this earth to do. What a colleague of mine said it best. He said, I needed a me, so I became one. I'm a patient advocate, and I needed a patient advocate before they were ever a thing. And so I decided I'll become one. I do firmly believe that we can all have a say about how things will go and where we'll end up. In 2013, I started an agency in North Carolina called Navigate NC, and I worked with largely in elder care. As the solo aging concept, notion, and population and demographic began to come forward, I realized a larger calling was at hand. I work with their patients, elders, their loved ones. I work with adult children of aging parents. It may be their first foray into any kind of caregiving, or it may be with those who are stuck or stymied, or long distance caregiving, when they're trying to assist their folks from across the country or across the globe. And I work a lot with solo agers. I want to help foster successful aging for those who don't have built-in family support as caregivers. And I want to do this too because I'm a solo ager. And so I've got some skin in that game. I've got some key phrases. These are my mantras I wanted to share with you. We've already talked about one. I needed a me, and so I became one. We can all have a say about how things will go and where we'll end up. And my favorite one is let's get out of the problem and into the solution. Please, everybody, if you're just joining us, place your questions in the chat. We're going to be pausing from time to time for questions. So you're joining a little bit of Patient Advocacy 101, and then we'll put the solo aging overlay on top of that. What you see here is an image of a pie, because that's the image that comes to my mind whenever I'm working with clients. I have 6 pieces to the pie, and I'll be introducing you to them in greater detail later. But these are the things that I work on. Medical aspects, of course, I'm a patient advocate. but I have strong feelings about getting your legal ducks in a row. Also financial. What's the caregiving pocketbook? How are we going to pay for it? What are resources that we could tap into? Insurance. What kind do you have? What does it cover? Do we need to make any changes? We deal with housing. Is our home set up wherever we are, in a home or in a community? Is our home serving us? Is our tool serving us, or are we serving it? And do we need to make changes within the home or change the whole home itself? And then the other big one, which we'll go over in more detail, is support. And that's where a lot of us are challenged. So we have a working definition here. The working definition is elder orphans or solos are individuals who by choice or circumstances function without the support system traditionally provided by family. Okay. That would logically include people who live alone. People who have no spouse or partner. Okay. People without living children or stepchildren, right? And people whose only child is disabled and doesn't have the capacity to provide support. And it's really, really a much bigger definition than this. Our numbers are growing, and the definition will grow and change as well. I'm happy to say that while our numbers are growing, that makes me happy. And there's a lot of things to celebrate as we go forward today, but we're also hidden in plain sight to a lot of people. We're coming into view, and solutions and providers and specialists like myself are stepping forward. It's really impressive to witness the renewed attention on the existing books that are out there and new books that are being published. Your show's popularity, Steve, is wonderful to see. I know your attendance is up, and requests for the thought leaders and other professionals in solo aging, requests for us to speak are up as well. This is our traditional, on this slide is our traditional definition, but there are greater considerations. First, you may have family, but you're estranged from them for whatever reason. Your children may live at a distance. We talked about that. They may live across country, or they or even deployed. That's another big one. They may be unavailable. Maybe your support system is having their own hip replacement, or maybe your loved ones are off on a cruise somewhere and we can't communicate with them when something happens in your life. Now, maybe there's unavailable support. And then sometimes unidentified support. Maybe you as a solo have not gotten to the point where you started to identify your support, and that's the work before you. And we're happy to go with you on that. Duo, maybe you have children. Maybe you're married, but you don't. This one's maybe you're married, but you don't have children. I get distracted by this one because I want to say DINK. Do you remember the phrase in the 1990s, DINK, double income, no kids? That's what duo has become. And a lot of people see their counterparts helping older loved ones, and they go, who's going to do that for me? It's a valid question. The other one is children or families are unavailable, unable, unwilling, the estrangement, or just sometimes people just don't care. And maybe there's a dysfunctional relationship. There's addiction and mental health issues in among those that you're expecting might be the ones that could care for you. And here's a touchy one that we will talk about more than one time, and that's maybe you're the same age as your spouse or partner or friends. Be careful with that one, and I'll come back to that and talk about why. I want you to read these really good headlines. Without safety net of kids or spouse, elder orphans need a fearless fallback plan. Yeah, single, no kids, don't worry. How to plan for aging without a family caregiver. Elder orphans hiding in plain sight. And the terms that we all now use, you know, if you Google elder orphan, solo agers, solo, oh, it's going to come up. You're going to have a lot of reading to do. So one night when you can't sleep, Google elder orphan, solo agers, or solo. The one thing I want to point out about this slide is look who writes this stuff. Kaiser, AARP, the New York Times. These news outlets don't write about something unless it matters. So my message to you, when I see stuff like this, we are a phenomenon and we're a thing. And I want you to realize that. Okay, now we're going to put the overlay of patient advocacy onto solo aging. You know, we know a little bit about what a patient advocate does now. We know a little bit about who a traditionally defined solo ager may be and the expanded definition. So let's talk about the work that I do with solo agers, and the ones that you see that are kind of in red there, medical, legal, and support. We're going to spend a little bit more time on those because I think they're germane to the situation. So here we are back at the pie, and you get to have this pie served up by a solo ager. I'm a solo. I have my story. I have my experiences. And so you get a patient advocate with solo aging experience and my professional reach as well whenever we're working together. So here we go. I work in these areas, and again, everybody's different, depending on what their needs are, what their questions are, and what their circumstances are. By and large, I place, well, lots of emphasis on medical because I'm a patient advocate. So that's kind of my jam. As has been mentioned, what's this new diagnosis? How's it going to affect me? How do I plan for this? I need information about symptoms. I need to know my trajectory. I need to know what is going to happen. And so we educate, we set expectations. We stand in front of the medical team, sometimes trying to delay a discharge from a hospital if there's no safe plans at home. This happens all the time. A lot of times a medical provider doesn't have a window into where you're going when you leave their office or the ER or the hospital after being inpatient. And so we've got to have things ready at home when we've got the time so that you can have a safe discharge and won't cycle in and out of that facility. It's also an important time to educate and make everybody think about what happens to this patient when they exit your door. And so I have a lot of opportunity to educate my contemporaries in the medical field as well. The next one that we talk about is very near and dear to my heart because I came out of the legal team on an EAP. So yeah, legal stuff is important to me, but it's also where solo agers have a lot of power and a lot of independence. The legal documents that we need to complete are great tools for us. You know, this is how, you know, everybody says, you know, as I age, I want to maintain my independence and control. And if this is true, this is how you get it done. Not only talking about how you want things to go after death, but also your advanced directives. What do you want your care to look like? Who do you want to make decisions for you? What are your wishes? And pursuing creation of legal documents is how you have your voice. You know, thinking about who will speak for me if I'm unable to speak. And this is a big one for solos because a lot of us haven't identified that yet. And it's a common and frequent discussion, and there's a lot of good ideas and legal tools out there. One I can remember coming upon two ladies standing in the hallway when I was teaching a class, and one of them looked at the other and said, Madge, which one of us do you think is going to keep our marbles the longest? And while that was a pretty funny little query, it was a poignant one. You know, that same question asked at 65, who's going to keep our marbles the longest, is an even more important question at 75. and certainly may have a different answer at 80 or 85. And so that marbles thing resonates with me. The financial I mentioned is the work with financials is about how are we going to pay for care, or what I politely call, what's the caregiving pocketbook? What do we have? Do we have assets? Do some people need to pay for their care by selling a home and moving somewhere different? Do we have long-term care insurance? Do you know what that covers, or how do you launch it? And what resources can we tap into, especially for veterans and concerns like that? Next is insurance. Again, the long-term care, do you have it or not? And what kind of insurance do you have? Does Medicare cover this? What's my copay going to look like? How do I decide on drug plans? Because I got a whole new slate in the last 3 months. And so answering questions like that, carrying the question to insurance professionals to get the information so folks can make good decisions. Same with housing. Is your tool serving you? Can you go back home? Can you live safely and comfortably there? Safety is always my litmus test. And I will go against my very patient. If I think it's not safe, then we're going to have to do something about that and roll up our sleeves together. I think the biggest one for solo agers is support. Lots of good conversation, lots of vulnerable feelings sometimes. I think it's a big concern, but we just have to build our support differently. We are not left out. We're just different. We have to pursue and build our support a little differently. My catchphrase there is called view it and do it differently. I was honored to provide commentary in an article that just came out, Carol Marrick's article in Next Avenue, Emergency Planning for Solo Agers. And she points out that as solos, we have to do a little bit of forethought about these kinds of situations, and we have to view it and do it differently, emergencies. But traditional support also is, how do I meet new people? How do I meet people that can support me? Or like the Marvel story, what if all my contemporaries are all my age? How do I meet anybody younger that might be a potential candidate to be my agent with healthcare power of attorney or financial power of attorney? How do I do that? And we're all still smarting from the pandemic and the isolation and loneliness that placed upon us. We're still getting our sea legs and coming back. And there are many new ways being developed to enable us to develop support and develop our circle of care, whether that's professional or our personal circle of care. Everything from a BFF to the agents who, with financial and healthcare power of attorney, that will help us make decisions when we're unable. I learned of a new one just this week. I'm preparing to move, and so I'm researching my new town. And on the Chamber of Commerce site, here's a new way for Nancy to find support. They had a function coming up called speed friending, like speed dating. And they actually have an event where you can go and meet new people, and there's a bit of a format to it so that you can meet at a library and introduce yourself and meet new people. And I thought that was a pretty new spin on an old concept. And so people are coming up with good ways to do this, and it's a big topic of conversation in every question and answer session I do, in every presentation I do, and certainly every small group meeting. I'm going to pause here and ask Steve if there are any questions that we need to field.
Yeah, there are a few questions, and let's see. Let me just run through them. And okay, so we got Martin who says, "How are you paid? One-time fee, yearly, etc. What happens to your patients when you either retire or pass away before them, who takes over for their care?
Good questions, both. Um, Patient advocates, independent patient advocates are private paid. We're not covered by insurance simply because, and I'll say this for me personally, I don't want to be covered by insurance because then my master, my boss becomes the insurance company and not my patient. I work directly for the patient and for their families and their loved ones, not for hospitals, not for insurance. You know, I work for you. Secondly, what happens when we retire or there are changes in our ability to serve you? I have a moral and a legal obligation to me. My moral compass says I've got to take you to the solution. I have to help you change hands, change reins. I need to make sure that my folks are covered. And you may find yourself back at a Google patient advocate plus your state. If we're worth our salt, and I feel many of us are, we'll get you to the next person. I can't let go of the folks that I had when I was serving in my Navigate NC agency. I had to make sure that they were all okay, done with, had a different patient advocate or knew how to find one if they encountered problems later on. As far as some people always want to know ranges of costs of patient advocates, and it varies across the United States. Depending on your need, depending on the credentials and qualifications of your patient advocate, and also regional differences. It can be anywhere from $100 to $350 or $400 an hour. Here where I live in the Southeast, it's a little bit more relaxed. I'm happy to talk with folks about my compensation in a complimentary consultation. And I'll always tell you that, you know, I'm not the most expensive, but I'm the best. I hope that answers your question.
All right. Okay. And then Wendy says, are you limited professionally or personally to taking clients that only live in your state?
No, not at all. Another really good question. Many patient advocates will consult from state to state. Sometimes it's problem specific. You may need one of our medical billing specialties. There are several patient advocates who do nothing but insurance debacle, medical billing appeals, and that's their jam. They can work from anywhere to help you wherever you are, as can somebody who is a disease specialist. Perhaps you are encountering cancer and you need specific cancer navigation for the type of cancer you have. We'll likely have folks who have experience there and will get you where you need to be. In North Carolina, I worked in North Carolina primarily and until the calls started coming in from other places. And so I recently closed my agency so as to be able to consult online from wherever I am to wherever you are. Always with the caveat, you know, if I'm not the best person for the job, it's my job to get you where you need to be.
Great. Let's see. This is a really good question that I get all the time. What's the difference between a patient advocate and an aging life care manager?
We get that question a lot as well. You know, if you're one of those people that study those Venn diagrams with the circles, we have a lot of overlap. We are very similar. We consider them a sister professional agency as well. I think that we're more medically oriented. Now, there are more aging life care specialists than there are patient advocates. They're a more established industry, and we don't have patient advocates everywhere, peppered everywhere as yet. That's a yet. I think we collaborate. We work a lot together. If I'm helping somebody in an area where there is no patient advocate, you can bet I'm trying to lead them to an aging life care specialist. And so I think just the medical expertise and depth is one big defining source.
Great. Okay. Kelly asks, regarding safety, what are your thoughts about people who have capacity and don't value safety as their primary concern versus staying at home, for example? And Kelly, I feel like every week I'm talking to an adult child that's concerned about mom and dad's safety and how the house is laid out and what have you.
Yeah, that's a big one. That's a real big one, and it's a source of a lot of uneasiness. That is something that we're absolutely consulting with you about. And it bears a lot of conversation. It sometimes medical reevaluation to see, maybe it's a medication issue. Where is their cognitive activity at right now? And akin to that conversation is one of a loved one will say, I'm the agent with healthcare power of attorney. When do I step in? When does somebody have capacity and not? And those decisions often go to their medical provider to call it. And sometimes their attorney calls it because they don't have capacity. They're deemed not to have capacity to be able to sign a legal document any longer. And it just changes how we get the work done.
Great. Okay. And then I was about to say our last two questions, but then we got another one that popped up but Elizabeth and Kathy. So Elizabeth says, how do I become BCPA, which is board certified patient advocate? I feel the need in my Spanish community. I love that, Elizabeth. A lot of these services that we talk about need providers that speak the language of folks that are not and understand the culture of different ethnic groups. And then Kathy says, what are the requirements to be a patient advocate? So these two questions are interwoven there.
Yes, they are, and both good ones. And I thank you for those. The requirements to be a board certified patient advocate require passing our certification exam. And if you want to certainly communicate with me, but look up PAC board, PAC board.org. That's our patient advocacy certification board.org. And you'll get information about how to become a patient advocate. Also, our professional organizations that I mentioned before, the Alliance of Professional Healthcare Advocates, APHA, and the National Association of Healthcare Advocacy Consultants, NAHAC, Greater National Advocates, GNA.org, and Health Advocate X. All of us have, there's information. You can also Google how to become a patient advocate, and information should render.
Great. And then Martin says, are you insured and bonded? Given the prevalence of elder abuse and financial fraud, is there any checks and balances, especially for those that are not mentally competent? How do you handle solo agers who do not have anyone to pay the periodic fee and they are unable to do themselves?
Okay. Great questions. Y'all sure can pack them. Yes, I am insured, and some people are bonded within their state. I carry professional liability insurance, as do I think all of us. It is a requirement of some of our professional organizations. I carry 1 million, 3 million, just like an attorney, and that's important to me because I want to be well credentialed for you. Let's see. How do I handle? I'm sorry, the other part of that question.
Like a solo ager. Well, somebody that doesn't have capacity is number one, and then the other thing is, what about somebody that can't afford a patient advocate? And I will tell you, this topic comes up on every profession that we talk about, whether it be elder law, aging, life care, and patient advocacy, senior move managers. It seems like the good thing is that most providers, as you had alluded to, have a complimentary consultation. And in that consultation, we can talk about budget and we can talk about what's available. And what I've been impressed with everybody, regardless with the profession, is coming up with creative solutions. So it may be more, advice or guiding you to a nonprofit or what have you is what a lot of the other professions had said in that area.
Yeah, I agree. It's my responsibility, I personally feel, to know about other resources. If someone doesn't have the ability to pay, then I I have the choice of doing some pro bono work. I have the choice of guiding them to where they need to be. And that means a familiarity with my state and other state structures. Maybe they need to go to the Area Agency on Aging, which is federal and has offices that cover every county in the United States. Maybe I send them resources that are at the top of the need, and then they can pare it down. And I let people know exactly what, when you get that 800 number, ask for this. Sometimes I prepare them with questions. And we need to know our local structure too. Oh, you have a Medicaid question here. What county are you in? And I provide them with, I take them to that. So we have the responsibility, if not us, then who? We need to know that too.
Mm-hmm. Yeah, and Catherine asks, sort of related to what you just said, is giving people guidance. She says, how if one employs someone from outside of one's geography, what role does that patient advocate play in locating good bedside logistics management if one needs to be hospitalized?
Good question. It depends on the scope of work when you and I are working together. Sometimes people, I'll be consulting with somebody, and if they need boots on ground in their area for specific reasons, I'll find them another care manager, patient advocate. Other times I'm saying, here's how you do it. Here's how and we Google together, and I teach them, here's what you must do. Here's what you must find. Here's what you must say. Here's some helpful articles about this. I bet that Steve Gurney has something on his website or a segment of one of his webinars on it. Our job is to load you up with the information so that you can make good decisions. Mm-hmm. Sometimes we handhold, sometimes we just provide the information and off you go.
Great. Okay, Martin has a follow-up. He says, to clarify, my question was, how does one pay if they do not have the mental capacity to do so, and they also do not have anyone to provide that function? And this Martin, Nancy, I don't want to sidetrack your thoughts and answer to this question, but this is one of the main reasons that I like these discussions about solo aging, because I think to properly answer Martin's question, it's a legal aspect of when we lose capacity. If we have not thought about this and gone through the process to assign health and financial power of attorney, then we are going to be thrown into the legal system. And there's not much. Well, there is a lot that a patient advocate could do if somebody hired, and I imagine that's what you and your colleagues are a lot of times hired for, is mom did not prepare her advanced medical directives and we need your help in navigating the system. But ideally, these discussions reiterate the fact that hopefully you've got a relationship with a patient advocate before a crisis occurs, and you've got the proper paperwork before potentially. It's not a guarantee that any of us are going to lose cognitive impairment, but if we do, have that paperwork in place. So that's sort of my thought on this, yeah. Nancy, if you wanted to elaborate on Martin's question as well.
Thank you, Stephen. What you said is right on. Nobody wants to be caught short. And it happens, and it's going to happen a lot more. We have to have these thoughts, conversations, discussions now. We need to take action now. Remember when I said, I want to maintain my control and independence, and this is how you do it. Having the conversations, realizing, oh, my back door's open in that respect. Or I need to find that person, appoint that person to be on my team. We need these conversations now, because you will lose your power if you get caught up in the legal system. If you're deemed without capacity to sign papers or make decisions, and we head down the guardianship path, you're going to lose a lot of your rights. So it behooves you to do it now.
Great. And then Paula asks, does Medicaid which would pay for care in a nursing home after your money runs out, pay for care at home instead. And Paula, again, this is what I love about the solo aging discussions is we go down so many different, it makes us realize how many things we need to be aware of. And again, this is one of these, another great reminder for me to bring on a panel of elder law attorneys again, because this is this is in their scope of work. However, the patient advocates and the care managers can also help folks in that area. But I would say, from my knowledge, Paula, there are some states that are pretty good at creating Medicaid waivers and Medicaid home care options. They're somewhat few and far between, though. It can be challenging to navigate that.
That's been my experience also. Our states are all over the place, and some of that is that they've expanded Medicaid services and some have not. So it becomes a funding issue sometimes. Your very good point about elder law attorneys in planning. There are people who have assets who will exhaust them. That's just their medical trajectory or their cognitive trajectory. And you can do what is called Medicaid planning. Let's sell the house, use that to pay for care for a while. When that's used up, we will have a plan to convert to Medicaid. And here's how we do it. Here's how we protect a community spouse. The elder law attorney is a really, really great resource.
Yep. Now, I love this question from Shanti, which says, even though I don't need an advocate yet, thank goodness, can I provide your contact info with my children for the future if they find long distance care difficult, or should I be the one engaging with an advocate? I wish everybody thought like Shanti.
Thank you for that forward thinking. I was feeling a breath of fresh air over here. And the care and concern for the people that you love should not go unnoticed as well. Just find out where we are. Establish a quasi-quiet relationship with somebody. There are some patient advocates that have worked with patients, and some got better, but they find a way to keep them on the books. Some do, some don't. In my particular agency, my experience was that people got better or things calmed down and we closed out the case, only to reopen it later when there was a new need. So know where we are, know that we exist, and know that we'll help.
Oh, okay. And Linda, thank you, Linda, for your reminder. What did I tell you before we started? It's like, hey, if you pause to take questions, I'll make sure that the questions don't derail the conversation. But Linda says, these are great questions. Can you also please continue with the presentation? Yeah, because we're about 10 minutes away from 1, and I think you can hang on longer if needed. But thank you, Linda. We do have a few more questions. We'll get to those. But Nancy, if you want to keep on going, and
Sure.
Sorry that we derailed it, but these are all fantastic questions.
Well, it's true, and it's a big discussion as evidenced by. So I'm happy to stay on as long as people do have questions after the presentation. Know that. So nobody goes home without their chance to ask. I just wanted to say that at the end of this slide, I used to think that I could be successful at this aging thing, because I thought it was my independence that was going to be key. My gumption, my stiff upper lip, the fact that I could go out there and get some information. And what I have found is that it's not independence, it's interdependence. We need to identify our team and understand the resources that are out there for us, and we're going to go up. We're going to do better together, and our numbers are only growing. That out of the problem into the solution, that is where I love to live. I'm so pleased to be here. I love to work with folks one-on-one, and also with any organizations that serve seniors, most especially Solo Agers, because I am one. I also run an online group now called Savvy Solos, and we meet every other Thursday for an hour online for discussions kind of like this. We go down rabbit holes and we have some fun and some laughs. The rabbit holes in memory lane, a happy mix. And you can find information and registration on the Savvy Solos. If you Google that, it'll come up, and you'll see videos about it. I also do a lot of speaking like I'm doing right now at conferences and events and online. And I just like to bang the drum about solo aging issues. We have good news. There's good news ahead for all of us. You know, I think it's a great time to be a solo ager. We're coming into focus. The press knows about us. The media knows about us. They may not know quite what to do with us yet or to call us yet. But I think that people are coming forward with tools. People are asking, how do I start a solo aging group? There are collaborations between universities and maybe the counties in which they're located. I have a lot of people that talk with me about, you know, how can I do something? How can I join a group? How can I start a group? There are folks coming up with ways to do that, models, formats, questions, group leading, group facilitator tools. One good one that I see employed a lot is called a give and a get. And all that is a harmless conversation where somebody will mention they've got a challenge. And then everybody chimes in. Oh, I've had experience with that. Or some people are listening and saying, that hadn't happened to me. What would I do? And so give and get is a great way to have an exchange, learn a little bit, develop fellowship and you know, further your community. I think it's also an exciting time to be a solo ager because we've got the opportunity to reframe the conversation about this. You know, for a long time, we were saddled with the term elder orphans or the unbefriended or in hospitals unrepresented. And so we've got a lot of sad terms, as does aging. Silver tsunami, that connotes bad. We've got a lot of negative language affecting solos and aging as a whole, and we have the opportunity to reframe this. We need to let people know we're doing just fine, thank you very much, and we know what to do, and we're going to help the other solos just like ourselves, and that there are bigger numbers than you know. There's also more solution under development than you know. Want to proudly let everybody know that there are solutions from the thought leaders in solo aging, the ones that you see writing books and out lecturing. They are also meeting together to form solutions. What can we do? How do we get people involved? How do we solve this support conversations with them and all the other things that we've touched on today? And so there's a lot of great activity going on. And I think through that, we're going to join, so, you know, we'll be able to drive solution. Our numbers may be hidden in plain sight, but by God, we're coming out, and there's good news ahead, in my ever so humble opinion. You know, I call it solos rising. You know, we can get the individuals and the organizations and the thought leaders and the books and the webinars, and we can muster all that together and really create good outcomes for everybody involved. And so I'm excited about what's ahead for all of us. That's my contact information and last slide. So you tell me, Steve, if you would like me to stop the share and we'll just talk. I'm not hearing you now.
There we go. Sorry about that.
That's all right. I'm stopping the share.
Yeah, okay, so let's dive into the remainder of these questions here. And for those folks who need to jump off, this is recorded. All of the chat comments will be recorded. Nancy, I have had a few requests. If there's any way to like PDF your PowerPoint to share that would be great.
I'll send it to you, Steve.
Yeah, send it to me and I'll put it up with the recording. in addition, at one point, you were talking about some of the different patient advocate organizations. If you don't
Yeah.
mind, when you send that to me, I'd love to drop that into the recording link as well. Okay, so let's see. Where are we at here? Okay, what does somebody do if a parent is entitled to Medicaid but doesn't want to apply for it? Helen, I've heard this quite a lot. I mean, there's a lot of challenges in communication, and adult children are sort of like they see this path, and then mom or dad jam the heels in, and I always advise, like when I have conversations with folks like that, it's sort of like if I'm not doing a good job communicating, maybe there's a way to bring an outside person that mom can build trust with, a patient advocate, an aging life care manager, maybe an elder law attorney. It might also be a friend. And I think that there was somebody who had a question. Oh, yeah. Do you ever work in conjunction with solo agers who wish to work with their friends as well as a professional just like yourself? I can't tell you how many times when I'm brainstorming with families that, and they're talking about trust and how mom doesn't listen to anything that I say. And then, does she have a best friend? Does she have a neighbor? Can you reach out to them? And there's a better dialogue, a more productive dialogue going on with the best friend or the next door neighbor. But Nancy, your thoughts
Yeah,
on this?
you're exactly right. It is the conversation, and sometimes we need to come from different directions or try a different direction. A lot of times folks don't want to hear it from a son or a daughter or loved one or neighbor, but they will listen to their doctor, or they will listen to their clergy, or they will listen to a professional like a patient advocate. So it's sending in the person to come at them from a different angle. One of the things, I often run into a lot of very proud people, and fiercely independent. And, folks have the right to make a bad decision. They don't have to budge on any of it if they're safe. They don't have to do what we want them to do sometimes, and that's just that's their right. I would say that we employ all kinds of psychology. I'm talking about it with a loved one. How are we going to get Betsy to do this or that? What will make her more amenable to it? And so we're talking about, well, that won't work, but this might work. One, as an example, we had a fellow who was resistant to any changes in care, almost any discussion of care. And he was a former military fellow. He had been pretty high up in the military. And what worked for him, what unlocked his door, was to say, John, you were pretty high up in the military. You were giving people a lot of orders. You had a lot of people reporting to you and under your command. And yes, I did. And I said, you got the work done by giving the orders, and the work got done by the people that reported to you. Yes. I said, same here. You're going to give the orders and make the decisions. You're getting the work done through other people. Unlocked it. But trying different angles like that, yep. And it takes conversations.
Yeah, there's no one secret because we're all unique and different people. But if you can unlock it, that's great. Steve says, good idea to have a file of life, emergency contacts, drugs, conditions, etc., on or in your refrigerator. I totally agree there. Vita says, Nancy, what an upbeat and inspirational presentation. Thank you. I agree with Vita there. Linda says, do or can patient advocates ever work in a contractual capacity with other social service agencies? For example, the Jewish Social Service Agency.
Answer to that is yes, I do. I work on projects and contractually we can work with employers, we can work with government agencies. and lend our expertise, our perspectives, carry the patient or the consumer perspective so that an organization can kind of get into their head, their plight, their challenges, because we act as conduit professionally for those folks. So yes, I enjoy, I came out of an employee assistance program where we were the conduit between patient, person, and resources, or patient, person, and professional providers. So absolutely, that's an important conversation.
Great. And then Monica says, how does one get a solo aging source book? And Monica, we don't have a specific source book for solo aging, but I'm dropping into chat the link to order the positive aging source book, which has resources that might be helpful to all individuals. Okay. Someone says, I understand 80% of nursing home patients are paid for by Medicaid. That's probably an accurate statistic. And one of the things that I know, like a public policy issue, is that the most efficient way to be spending Medicaid dollars? And we all know that some folks don't need a nursing home, but they're there because they're impoverished, and that's the only place where they can be cared for and live. And there's a lot of movements out there to spread that Medicaid funding in more efficient ways, but we all know what it's like making change in government, and it's very challenging. And let's see, here's another one from Elizabeth that on the communication front, she says, if possible, if the parent doesn't want to apply, can we get power of attorney? Elizabeth, this is just a reminder that I need to get an elder law attorney on here. It's been a few months. This is a great question for an elder law attorney, but Nancy, any thoughts on how somebody can get power of attorney if a loved one is resistant?
Resistance does not mean lack of capacity. Just means you're going in different directions. The person that has to designate that healthcare or financial power of attorney is the patient. And they have to have capacity so as to do that. But it is a good conversation to initiate, to make your designations now thoughtfully, understanding what they mean, who will speak for me when I'm unable to. Like I may be temporarily gooed out on medication in the ER, and it may be just a few hours. Mm-hmm. We saw it a lot in the pandemic. We saw people that were intubated and couldn't. So it's a conversation to have now, and it takes on and if you're the agent, it takes on, your role will grow, and it requires counsel from a patient advocate and from an elder law attorney as to moving into that role. Yeah.
And the conversation, I was involved with an online conversation right before this today, and one of the things that is not a bad idea is that, let's say that you're having challenges in communicating with a loved one, your parent, what have you. The next time you go and have a conversation, consider like recording, and not recording it to share, but what I would challenge folks to do if you're finding resistance is listen to how you are talking to your loved one and reflect on how would I react if somebody said the same thing to me? Because what I found is that when we're in this role of a compassionate adult child caring for a parent, is that oftentimes the language that we're using is very ageist, and it can be demeaning with no direct intention to be demeaning. And when people make adjustments, they oftentimes find incredible results.
And may I add to that, that it's certainly more than one conversation. You know, there's this terrific website called Talk Early, Talk Often. This lady's been rocking it since the 90s. Talk early, talk often. We need to have conversations like this more than one time. And when you're closing out one, say, gosh, you know, this bears repeating. We're going to be talking about this again. Or may we talk about this again next Tuesday? And so it's a series, and they're an evolution.
Wow. Thanks for sharing that. I had no idea about, do you know this who
we communicated a long time ago. I just picked up on her back in the 90s, and plus I just think it's the catchiest little name.
I love it too. I'm gonna track her down and see if we can't have her on one of our discussions. But
there you go.
wow. Well, here we are. We definitely went over the time. Doesn't surprise me. I think anytime we throw solo aging into the dynamic, it's very lively with lots of questions and comments. Nancy, you're wonderful, and thank you so much for sharing your time with us. And again, you're the star of the show today, but I have to say that the audience and your thoughtful questions were absolutely amazing, and I love it. And you never fail me. In 2.5 years of doing these things, we've never done one where we didn't get at least 1 or 2 questions. And that's what really drives this from being somebody lecturing to you to where we create an environment where you are driving the conversation. So thank you, everybody.
Absolutely, everybody.
All right. Talk to you soon.